Okay, can I begin by welcoming everybody to Adults and Health Scrutiny Review Board meeting. I think we're just about core it, and thank you very much for being in attendance so close to the elections, because that was always one of my anxieties that people may have other priorities. Have you got any apologies?
From Kirsty McMillan, she sent her apologies.
Okay, can we note that?
Yes.
Item 2, late items to be introduced by the chair. I do not have any. Item 3, have we got any declarations of interest? No. Can we go on to item 4, minutes of the meeting held on 2nd of February 2021. They have been circulated. I don't intend to go through the minutes page by page, but if you've read through them and if you have not spotted any glaring mistakes, can we approve those minutes?
Yeah, we can.
Yeah. They've been moved, yep, and seconded. So we approve those minutes. And that takes us to item 5, which is COVID-19 vaccines update. And we've got Stephen Lloyd with us, who's going to cover that item for us. And then the second bit on the same item is restoration and recovery briefing. And Craig is going to cover that for us once we've covered the first bit. So it's over to you then, Stephen.
Yes, thank you to Councillor Hussain, and good evening, colleagues. For those that don't know me, I'm Dr. Steve Lloyd. I'm the Executive Medical Director of NHS Derby and Derbyshire CCG. I'm the Programme Senior Responsible Officer for the COVID-19 vaccination programme as it pertains to Derby and Derbyshire Integrated Care System. So I put together my comms team have put together kindly a presentation for me to share, and I'll talk through the detail of this as we go through, and happy to take questions, of course, at the end. There are some restrictions that are applied nationally in terms of information share on certain elements of this, but what we can share is where we're at now. So the vaccination programme in Derbyshire and indeed nationally has been running for over 100 days. Now, ignore that figure you've got in front of you there, 670,000 vaccines. That was of 5th of April. Where we were at yesterday, 19th of April, we delivered 763,400 vaccinations across Derbyshire. That's city and county. Of those, 595,000 plus were first doses of the COVID vaccine, and second doses totaled just short of 168,000 second doses. And just to give it an idea of the scale and pace of this programme, just over the weekend, just gone from Friday to Monday, we delivered 36,000 vaccinations. So that gives us some sense really of how this programme is progressing and the significant progress that we've made through it. Now, I'll just remind colleagues in terms of how this is structured, this programme, and how it's delivered. So we usually describe pillars of delivery of vaccination. So I've talked through previously about hospital hubs, talked through previously about what we call local vaccination services. That's primary care led. We've talked about community pharmacies, and we talked previously about vaccination centres and in old money, the mass vaccination centre, which is located at Derby Arena. Now, the Derby Arena site is in two parts. It's a primary care led site, and together in the same building, the vaccination centre site. And just keep that in mind when we talk about the different pillars of delivery. But overall, I'll talk through some of the detail of this going forward. We're performing very well, and it's a credit to the clinicians on the ground, to the support teams supporting those pillars of delivery, and to the providers across the healthcare system and all parts of the healthcare system in supporting and managing this program going forward, and also, of course, the invaluable support from our local resilience forum partners, and last but no means least is the volunteer element of this. So each pillar of delivery is not acting in isolation. It's spread across the workforce and the support to those elements. And like I say, we've progressed very well with this, I'd like to think. And in general terms, as we know through the media, there are phases to this. So the phase one basically is all those over 50 years old, including the clinically extremely vulnerable and also those at risk from COVID-19, the whole tranche of carers, NHS and social care workers, and collectively that's cohort 1 to 9, so that's phase 1. Then we move into cohorts 10, 11 and 12, which essentially are the remainder of the adult population nationally and locally, of course. So at this pivot point now we're entering into phase 2, so that's beginning to address cohort 10, 11 and 12. And at each of these waypoints, as I described them, there's a huge amount of planning that has to go in place to ensure we've got robust infrastructure to support the programme going forward. One of the key delivery elements of this programme is through the primary care networks, the PCNs, and they lead the local vaccination sites, the LVS sites. And as colleagues are aware on the call, there are 15 PCNs in Derbyshire as a whole and 5 in Derby City. The 5 in Derby City operate collaboratively through the arena. So to deliver phase 2, cohort 10 and above, this is on a national contract, similar to the contract that was offered for the phase 1. And there's been not just negotiation, but discussion around Derbyshire and Derby City as to PCNs going forward into cohort 10. And I'm pleased to report for the committee that all 5 of the Derby City PCNs have signed up essentially to what's called the enhanced service contract to deliver cohorts 10, 11 and 12. 3 other PCNs outside of the city boundary were in discussion. 2 have come forward of those to support the programme going forward. 1 PCN covering the Swadlincote area has opted out, but we've got a robust plan to cover that area, and I can share details of that if necessary going forward. So we're on with it basically as we get through the cohorts, and again, pleased to report public support has been very strong for this. There have been some occasions, as you'd anticipate, in healthcare settings where there are sort of disagreements around bookings and so on and so forth, but there was a very, very few indeed, and I wouldn't have included this on the presentation, to be honest with you. And again, in terms of the engagement we have with partners and stakeholders in the programme, we've got a very active comms team and support through those elements. So headline updates in terms of the cohorts that I've just described. So this slide essentially is describing cohorts 1 to 9. And as colleagues are aware, this is a national commission programme and we have to adopt the policies of the national team, and that's coordinated through our colleagues at region and through ourselves at the Derbyshire ICS level. So we've adopted an age cohort approach, basically from the start of the programme dealing with those most at risk of COVID-19, which of course comes essentially with age and long-term conditions. So the first 4 cohorts were the first tranche that we had to address, and then it's tipped down in an age band fashion down to cohort 9 and now entering into cohort 10. What we're describing on this slide is essentially what's the cohort penetration into the population that we've delivered first doses to. So as you can see, I'm very pleased to report a good uptake across our age cohorts. Bearing in mind this is a dated slide, we are getting to a satisfactory level of 90% plus on virtually all the cohorts in the most vulnerable in phase 1. Still some work to do, obviously, at COVID at risk group, which is a huge cohort in terms of numbers. That's over 150,000 people, and that's primarily the job card of general practice and the PCNs to address that, but very confident that we'll get to that. The 50 to 55-year-olds, 88%, that's a reflection of a moment in time as we tip forward into phase 2. So very good progress overall. Where do we stack up in terms of nationally and regionally? This small pictorial here demonstrates where Joined Up Care Derbyshire is nationally, in a very strong position in terms of vaccine delivery, in the top 5 in the country. And that's despite the complexities of the programme. I think it's a little bit unfair on all other ICSs, because each ICS will have its unique problems to address in terms of rurality, urban populations, deprivation, and so on and so forth. But it just gives a strong sense of where we're at. And again, that sort of reflection of challenge feeds into a constituency view of this, and certainly not underestimating the difficulties faced in actually ensuring that we've got adequate penetration into the communities as a whole. It's easy to be dazzled by a dashboard that reads green across. I'm more interested as Programme SRO in those that we're missing and have the potential to miss, and I'll talk that through shortly, because I've always adopted in this programme a position of equity and reach out into communities as far as possible. And that is our ambition, not just the strategic intent of covering off as many people as possible in the population, but actually getting into those communities most at risk historically, and what can we do about it. This slide, again, just gives it's a busy slide, this, which essentially gives a diagrammatic of where we're at in terms of performance on a constituency cohort level. Oops, pardon me, lost that. Just bear with me. Just trying to get to the bottom of the slide, basically. So again, that's a different lens of looking at this in terms of cohort penetration. A very high, primarily rural constituency in North Norfolk. How does that stack up against what we see in Derby North and South? And how does that look set against an inner London constituency? And you can see satisfactory progress. For me, the actual overall numbers, like I say, can be somewhat bedazzling. And for me and for the team, really, it's looking at where are the gaps now in terms of cohort penetration, and what are we doing? What are those delivery pillars doing to address those gaps? So that just gives a sense of where we're at in terms of cohort penetration. In terms of tackling vaccine hesitancy, this is always a very big and live issue for all of us, basically, and we do hear this remorselessly on the media, and it is important because, like I say, we need to be absolutely confident and assured that we are getting into our communities to deliver this vaccine and to deliver an offer as far as possible close to those communities going forward. So as I've described in Derby City, we've got the mass vaccination centre site at Derby Arena, we've got the PCN site at Derby Arena, we've got 4 community pharmacies in the geography of Derby City, and we've developed a number of approaches to get into the communities, as it were, going forward. So what's our approach to this? It's about informed choice. It's about getting into those communities, like I say, who have health inequalities, because those very same folks who are dying disproportionately of COVID-19 are the same communities potentially that can be the most vaccine hesitant. And this sort of reinforces the historic health inequalities that we've seen, and through the lens of the COVID-19 vaccine program, it really brings it into sharp focus. So our role basically is to close this gap and to work with communities and tailor an outreach to them. And that slide just describes essentially, you know, the ethos and how we're working through that. So it's all about engagement, to be frank with you. It's about utilising networks. It's about credible influencers. It's not being parochial or patronising. Yeah. It's about information. It's culturally appropriate, and understanding how our communities work, how our communities get together, and actually utilising the people we've got in our teams as champions in those environments. And we've done a strong piece of work through the Health Inequalities Group with our colleagues in local authority to progress this. And this is an ongoing thing. It's not a stop-go. We've got to get into the communities. So, for example, and there are some more examples in this slide, which I'll just touch on rather than going into the detail. So, for example, in BAME communities, particularly around Pakistani communities or people of origin from Pakistan and from Bangladesh, we're reaching out into those communities and offering mobile pop-up sites to deliver the vaccination. There's an ongoing conversation with the West Indian community about the potential for using mobile pop-up sites for vaccination in those environments. We've done a lot of work with community pharmacy, for example, about developing a local offer into those communities. And Wilson Street Surgery in Derby City have done some fantastic work with vaccinations around the homeless groups. And that's been well recognised regionally as an excellent piece of work and an exemplar in that work. So for the homeless population in particular through Wilson Street, we're achieving vaccination penetration up to 90% of that population, much lower in the county, but it's actually utilising what's worked well in that environment and how do we adapt it into other settings and into the county. So just some examples like I've touched on with this, around the communications element, around the information element, about getting into the communities, about training the trainers, about influencers, about our people as champions. And the work we've done, I was on a regional call this morning, the weekly regional call, thinking about capacity and delivery of the vaccination. And we're certainly held in high regard in terms of the work that we're doing on a regional footprint. And I'd like to say, you know, we're at the top of the pile on this regionally, and that's well recognised. But this is a dynamic programme. We can't just sit on our laurels. We've got to keep pushing on this because we've got to get the completion of this programme. Our ambition on this is first week of August. Obviously, the constraints on that are obvious in terms of vaccine supply at a national level and managing that workforce alongside the businesses as usual as it develops now, that Craig will touch on shortly in terms of restoration and recovery of service, and also beginning to look forward to what's developing as the phase 3 of this programme, which is colloquially known as the boosters. but this is more about revaccination. And I'll be on a regional call this week to start thinking about when, how, and what groups are addressed for that, and how do we link that with the previous flu vaccination programs that, again, we've managed successfully in Derbyshire. But also, for me, it's about reflective learning, what's worked well in this program, particularly that outreach into communities, and how do we do good stuff in terms of population health going forward on the back of this program. So there's a lot that's been learnt through this program. There's a lot indeed about collaborative working as a healthcare system, and more widely as a system of stakeholders through the local resilience forums, through our local authority colleagues, and how do we keep that momentum going into other spheres of healthcare. I'll pause at that point, Councillor Hussain, and happy to take any questions.
Fareed, you're on mute.
Sorry. Can I, Stephen, can I welcome the news that we appear to be slightly ahead of the program? Personally, I was booked in for my second dose on 1st of May, but I got a call last week alongside my wife that it could take us last week. So I don't know whether that pattern is being repeated, but I have heard it from other people that they were rung up and the appointments were actually brought forward because they were ahead of the program. Secondly, if I could ask a question around the gap that may have been created by hesitancy factor in the communities where there is greater hesitancy. Are we now in a position, because we'll have access to some numbers now, for example, if we have information which tells us that we've got so many hundreds of thousands of people between, say, 80 to 90 age group from the minority communities, and normally we would expect everybody to come forward and get vaccinated, but do we have a separate percentage which actually tells us or shines some light on what's happening within minority groups? Generally speaking, I think we've heard it in the newspapers and there's an acceptance that as a minority communities, generally speaking, you mentioned Bangladeshis and Pakistani, and to an extent some people say a similar perhaps hesitancy is also reflected in the African Caribbean community, but I don't know the extent. So I'm just wondering whether you've got that information which then paints real-time picture in a sense in terms of what's happening locally in our areas.
Yeah, thank you, Councillor Hussain. Very, very valid observations there and very valid questions. Nationally and locally, the focus is very much, as you described, on particularly on Black, Bangladeshi and Pakistani communities and people of those origin, not exclusively, but fundamentally those three groups that were of concern really in terms of vaccine hesitancy. And the data that we've got does gives us some reassurance in terms of how we're getting into those communities. And I've asked for that specifically from the team just to give us a time set of data on this to ensure that there is full coverage of those communities. So, for example, we've done an awful lot of work, as I've described, with the Pakistani community and the Bangladeshi community. The biggest lag at this point in time is with people of African and Afro-Caribbean origin. So in terms of data, I'm just looking through the notes I've got in terms of what we actually hold. We have got good data on this now, and it's beginning to drill down into individual communities. So the main lag is in the community of Black origin. So currently that's 25% behind the white British population in terms of vaccination penetration, much less in other groups, and we're trying to track this on a timeline basically to ensure that gap is reducing, and so we know where to target our efforts in terms of both deploying the vaccine on a pop-up basis, but also putting in more support to those communities for educational reasons. I can share some data offline to give you assurance. Like I say, there is some restriction in terms of data share on a national level, but in terms of where we are with our communities on an East Midlands footprint, we're certainly at the head of the pack in terms of our work and ambition around ethnic communities. The second level in terms of hesitancy is the more practical operational hesitancy. And obviously the news of AstraZeneca vaccine in particular, would that have an impact in terms of second vaccine uptake? And what we're tracking at the moment is a 6% what we call missed second vaccine through AstraZeneca, compared to a 3% with the Pfizer vaccine. And that's a really good figure, I have to say, because certainly in other areas of the Midlands that you're looking at 18%. So the work we've done in terms of comms and engagement has significantly reduced that element of vaccine hesitancy as well.
Excellent. Okay, anybody else? Diane?
Yes, please. Evening, Stephen. You've actually just answered my question, because it was about the hesitancy on the AstraZeneca for the women, more specifically, because it is, it does affect the women more. And I was just going to ask if there was any decline in the acceptance of the second dose. So you've answered that for me. Thank you very much.
The trick is now getting the pathway and process in place to cover off those under 30s in particular, and balancing that against vaccine availability, particularly the alternatives, the Pfizer and the Moderna. But we're on with that, I have to say, and we've got a robust process around that.
Councillor Pegg, I think I can see your...
Yes, thank you. Just following on from what Diane said about the impact of the AstraZeneca on the second dose, has there been any impacts on the people on the uptake of the first dose since the news of the AstraZeneca?
Not that we've observed substantially, I have to say. The main focus at the moment is missed second doses, because we're moving now substantially into the second dose program as well as the first. But I have to say, certainly at an individual practice level, you will get these queries coming through about, is there an alternative that people can use? But fundamentally, there isn't a choice on this at an individual level. This is dictated by national supply and national team. So it's how would you say bluntly, it's take it or leave it, but actually the people who leave it are very few indeed. And that's the assurance we're getting in terms of what we're tracking in cohort penetration 1 to 9, and what we're beginning to see emerge now in cohort 10 as well. The uptake is very solid and very substantial.
Thank you.
Please correct me if I'm wrong. Have we got a total population, including Derby and Derbyshire, of around about just over 1 million? Is it 1.1 million, or is it just over?
The eligible population is just under 1 million for the vaccination program. That's what we're tracking.
Right, but it's not. Yeah, I don't know what the total is, but it may be 1.1 million or somewhere around there. So we've already vaccinated around 700,000, and there's only around, according to your figures, another 250,000 to be vaccinated for us to get to a situation where everybody's had at least one vaccination, is there?
So just for clarity, that figure of over 700,000 doses, as I said, is a combination of first and second dose.
First, right, okay.
So the first dose figure, like I say, is well over 500,000 now, 585,000, and that gives a sense of the scale of the program. So we're moving into concurrently, at the same time, first and second dose patterns here.
Yeah.
So as we cover off 1 to 9, there's a time lag, obviously, where you move into second doses. And essentially, we're not even halfway through this program yet. That's the key.
Yeah, sorry, I misunderstood you.
Yeah, I mean, the first doses will give substantial protection against severe COVID-19 and the consequences of that, and it will substantially reduce potentially the transmission rate, but it's maintaining that immunity through the second dose, which is absolutely key and critical. And this is one of the key messages: is one dose is not enough. It's got to be the full course before we even consider, what phase 3 would look like. But nonetheless, we're making substantial progress towards completion of the first dose element of that, concurrent with beginning delivery of the second dose element, with an ambition, like I say, to get this completed in August. Like I say, the main constraint now, as I see it, I'm confident in the infrastructure we've got. I'm confident in the workforce assumptions that we've made. I'm confident in our teams. I'm confident in our people and population. What we need is the vaccine supply coming through.
In terms of the eligible group, is there is it meant to be for adults only, people who are over 18, or is that where it starts, over 18?
Essentially, it's the adult population that you look at, over 18. We've got to address that whole population.
Okay.
Could I just pop in there, Fareed, please?
Yeah, sure.
Yeah. There is talk of a new variant that will probably affect the children. Will we? But will it be the same? Oh God, I've lost it. Will it be the same dose, or will we have to go back to all the rigmarole of having it put through all the clinical things for the children, or are they already working on something? Do we know? I
know where you're coming from here, Diane, and I'm certainly taking my hat off as...
it's been a long day. That's all I can say.
So if I take my hat off as Programme SRO for COVID vaccinations and put my LRF Science and Technology hat on, the chair of that group, certainly the variants that we're seeing in the UK at the moment are predominantly the B117 Kent variant, and that superseded the original SARS-CoV-2 virus. As we know, there is slightly higher transmission with the Kent variant, and possibly higher morbidity with the Kent variant. Substantially, the vaccines we have at hand and are deploying are effective against that variant. There are a number of other variants of concern that I know Robin will know this inside out, that we need to keep an eye on: the South African variant and the P1 Brazilian variant. The information we have to date gives us some assurance in terms of the effectiveness of the vaccines currently deployed against the more severe elements of COVID-19 through those particular viral variants. The most recent one that's hit the news is this so-called Indian variant. Essentially, that has a number of mutations similar to the other variants in terms of spike protein and its potential, and it is a potential only for increased transmission and morbidity. What isn't known is the effectiveness of vaccines against that. I don't think it would be scrub the program, start again. I think substantially, obviously, we complete this program to get ahead of the current viral scenario. And then when we move into phase 3, that would be the discussion, obviously, about does the vaccines that we deploy, would they be effective at that point in time, or would there need to be a tweak, as it were, of the vaccines from the pharmaceutical companies? But substantially, the evidence suggests at this stage that the vaccines we've got are effective, and certainly the data that we see gives us very sort of robust assurance in terms of the effectiveness. And when you look at what you call the seroprevalence rates on the population as a whole, i.e. that proportion of the population that have got positive antibodies, on a population basis, and we're talking about the whole of the UK now, over 50% have now got antibodies to SARS-CoV-2, and only a very small proportion of that is through natural infection. So the default is obviously it's the vaccination program which has pushed those numbers up to give that protective effect. And if you look at the seroprevalence in the 70 to 79-year-old cohort, for example, you're in the 90s, basically 90% plus in terms of positive antibodies giving a protective effect. What's difficult to triangulate at this stage is how long that immune response endures for. And that's the conversations now that will be held around phase 3. When does that launch? As well as the question, like you flagged up, which vaccine or which tweak of the vaccine is necessary at that time. But there are no variants out there on a global scale which would be classified as a variant of high consequence, as they say, where you've got complete immune escape and a substantial risk of increased mortality, basically.
Oh, that's good. Thank you.
Just to make sure I've understood you correctly, so all the mutations that we are aware of, which have emerged over a period of time in different parts of the world, the vaccines that we've got actually appear to be as effective on those, despite those mutations, they're as effective as they were in cases where there have been few.
There are concerns. They are classified as variants of concern, particularly the South African variant. And there have been reports in terms of potential reduced effectiveness of the vaccines. But the effectiveness of reducing severe COVID-19, I think, is still there. So it doesn't undermine the vaccines program substantially, but this is part of the effort, if you want to call it that, in terms of testing ability that you've seen deployed in parts of the country like London currently, to understand where we're at in terms of a variant and to potentially control it. But like I say, just coming back to the vaccines perspective, I don't think there's anything which would substantially undermine our confidence and faith in the vaccines that we've got. And the message is still the same to the public: get vaccinated, maintain safety. This ain't over yet.
Okay, if there are no more questions to Stephen, then can we ask Craig to take us through the second part, which is restoration and recovery?
Thanks, Chair. No worries. Good evening, everybody. So I appreciate that the information that's been circulated with the agenda is probably quite dense. There's quite a lot of information in there. So what I've done is just pull together a short summary presentation that hopefully pulls out the salient points, and then clearly can have a conversation at the end about the NHS's focus on restoring many of its services over the next few months. So hopefully colleagues can see this. So what are the key messages as we embark on the next phase of our restoration efforts? So as Steve was saying, there's a big focus within primary care to roll out the vaccination programme, but against other aspects of care delivery across primary, secondary, mental health and community, We're now in the space of thinking about how we bring services back online to deal with the many people who are waiting for treatment. So there's probably 5 key points I want to get across today. The first is, as you'd expect, that our workforce and supporting our workforce is a top priority for the system. It's a top priority for many systems, given the extreme pressures that they've been working under over the last year. And I'll come on to some of the initiatives that we are looking to introduce to look after their health and well-being. So that's a really key point, and it underpins everything that we're doing when we're talking about recovery of service. A couple of points on the sort of the demand side. So as you'd be aware, that the volume of COVID hospitalizations is really low now. So less than 1% of our acute bed base is occupied with confirmed or suspected COVID. Which is really positive, because back in February, at the peak, we were seeing across Chesterfield and UHDB in the range of about 30% of its bed base occupied with COVID. So a dramatic reduction that we've seen over the last few months to the lockdown, and due to also the impact that we're starting to see through the vaccinations. But I guess against the backdrop of low COVID bed occupancy, we're starting to see some of the non-COVID emergency volumes return. Going to the A&E departments, folks going back to their GP surgeries, so there's a volume sort of increase compared to what we've been seeing over the last few months in terms of non-COVID presentations. Also, what we see is a more complex presenter in general coming through, which again we need to understand in a lot more detail as we restore service. Actually, there's a strong chance that actually we're going to see folks coming back into the system with more complex presentations than ordinarily we would expect to see at this point in the year. So some of the work that we will continue to do when we're talking about emergency care is a focus on managing more lower level complexity demand through a lot of the other pathways that we've employed during the last 2 waves. For example, the significant investment that we're putting into 111 services, using 111 is our main default sort of triaging point to point patients in a direction that perhaps is more convenient for them, and ensuring that they get timely service. And then also on the sort of the flip side, the patients who are admitted into the hospital, our priority is about maintaining that really good discharge performance that from hospitals that we've seen over the last year. And indeed, maintaining the good performance with regards to emergency care demand management is an absolute prerequisite for supporting the restoration of our elective care programme, which I'll come on to in a minute. So on the elective care side, as you can imagine, and I'll share some statistics in a short while, we've got a significant backlog that's built up over the last year or so. This is going to be a plan of 2 halves, right? So we've got a window now from now until, say, August, September, where we've got an opportunity to start to accelerate our elective operating programme. And the focus of our hospitals, of the system, is about prioritisation of care. So we will be operating on people who are clinically urgent. And that's where our focus currently is. So I don't know if colleagues will kind of hear it referred to as this, but we're focusing on a cohort of patients that are classified as P2 and P3, which is effectively high priority care requiring surgery within a specific time period. And our current ambition is that by the end of Q1, so around June time, we would have brought the P2 patient cohorts down to pre-COVID levels, and the P3 patients, the next sort of complexity down, would be restoring our levels down to sort of pre-COVID levels by sort of Q2 21-22. So I'll come on to that in a bit more detail in a short while. But I guess the last point, and this is a caveat to clearly a lot of our planning work, is COVID, and clearly the resurgence risk that Steve talked about, whether it be new variants, whether it would be vaccine efficacy. And our current working assumption is that in this short-term elective recovery plan that we've formulated, that takes us to August and September, that we think we can deliver it against a backdrop of very marginal amounts of COVID demand. So if this plan works, if we can keep COVID down to the levels that we currently got it effectively. And this is what I was sort of talking about in terms of a plan of two halves. And actually, if we can kind of keep that COVID level down, manage the non-COVID emergency demand to an acceptable level, it will give us the space in order to start to operate more and increase our run rate in terms of operating. But clearly the second half of the year, going into 2022, we're going to be having to think about a number of variables. Firstly, COVID. So what does a third wave potentially look like? As well as actually other communicable diseases that have actually been historically quite low. So influenza and norovirus. So actually the worst case scenario of a resurgent COVID position and increasing in the influenza virus as well as norovirus. So yeah, we've got a lot of planning to do for the second half of the year. So what are our priorities then for the year ahead? Sort of 5 broad priorities. The first, as I talked about earlier, supporting the health and well-being of our staff. The second, as Steve has mentioned and is leading on, is the delivery of the COVID vaccination programme and potentially a third phase of that. The third aspect, I'll touch upon in a bit more detail in this presentation, is actually making sure that some of the good things that have come out of COVID in terms of how we deliver care for patients can actually be maintained going forward, particularly with regards to elective and cancer care restoration. The fourth aspect is really important, is primary care recovery. So against the backdrop of a very difficult and challenging vaccination programme, but we're also bringing back business as usual primary care services. And then finally, as I talked about earlier, we've got to keep transforming our community and urgent care pathways, providing real alternatives for patients to their ED departments so they can get their care quicker and in a more time action that we're taking. As a bit of context, so if you look at the absence rates of clinical staff across our main NHS providers, it's around the sort of 5 and 6% mark, which is typically where we'd expect to be at this time of year. We're actually operating at a high level sort of January, February time. But one of the features of the absence rate that we're seeing currently is that about a fifth of those people, of those staff members are absent due to COVID-related illnesses or effects. Now, we're expecting actually that proportion to be increasing over time. We don't know to what extent, but nevertheless, it's still quite a significant proportion of patients staff who are likely to be off due to COVID-related issues. And I guess that's a challenge that we face as a system. But also another challenge that we faced is that what we've seen over the last 4 years in terms of NHS staff absence is an increasing proportion of staff off due to mental health related issues. That's been increasing year on year over the past 4 years. And actually, what we haven't seen washed through in any real significance as yet is potentially the adverse effects from a mental health perspective of our clinical workforce that again remains a risk to our recovery. But as you can imagine, there's a hell of a lot of work going on right now across all of our providers to really look after their staff. Investments in wellbeing initiatives, a lot of decompression and reflection time, actually making sure that staff can take the annual leave that's been accrued over this last 12 months, a proper rest and recuperation. I think a radical regrading actually of our occupational health offering for staff as well. So access to a lot of the psychological and special support that our mental health providers operate. So giving staff all access to that as well. So hell of a lot of work going on in that staff health and wellbeing arena. Appreciate the slide is quite busy, so I'll just cover off the salient points. So just to kind of re-emphasize some of the urgent and pressures that we're now seeing. So what we've seen clearly over the last 12 months is all types of hospital demands in the main reduce due to COVID, we're now starting to see a resurgence of the demand volume. So as a bit of context, in March, so March 2021, we actually saw more patients in our ED department than we saw last March. Now, we know there's a bit of a COVID effect in last March figures, but nevertheless, quite a sizable increase, say, on the January and February position. And I guess the kind of take-home message here is, which we're kind of spending a lot of time to think about its impact, is it's not just about volume, it's about that complexity of care. So patients who perhaps haven't been able to access their long-term condition review in primary care, perhaps are suffering more exacerbations of chronic conditions. Actually, are we starting to see a significant increase in those patients coming back into the acute sector? And that's something we need to be careful and mindful of as we restore services. Clearly, we're doing a lot of work though to improve our urgent and emergency care pathways. So hell of a lot of investment's gone into this integrated urgent response offering for patients. So NHS 111. We are thinking about what the urgent treatment centre offering is. Obviously in Derby, we've got an urgent treatment centre, but also across the county, investing in facilities in people's communities to make care a lot closer to home, so that they can access it quickly. A lot of work going on the sort of acute admission avoidance piece. So if patients do have to go into hospital, that actually they're treated in a quick and efficient manner, in an effective manner as well. So a lot of work going on in that space. And then, as I said earlier, some of the really positive service developments that we've put into place over the last 12 months on the discharging side of the pathway, we've got to keep focusing on that as well. And one of the initiatives that it sounds really, really innovative that we'll be looking to roll out this year is a new initiative called Team Up, which is effectively making sure that we can link clinical teams together, whether it be a patient's general practitioner, community therapist or nursing, whether they need sort of a mental health nurse, as well as that wider adult social care offering. Actually, one team proactively supporting patients in their home, so we can really start to see much more proactive care being delivered, as well as opposed to that kind of reactionary care offering that occurs in the hospital. So new investment going into that initiative across Derby, across Derbyshire, that we're looking to hopefully see in play before we hit the winter periods. A little bit on the elective care side. So colleagues will clearly be aware of some of the pressures being reported in the press and previous meetings to this as well. So at the end of February of this year, we're just under 80,000 patients on a waiting list. That's across Derby and Derbyshire as a whole, which is just over 7,000 more than the position that we had in March. A significant increase, but it's the tail of that waiting list which is a real concern to us. So just under a third have been waiting longer than 26 weeks for their treatment, and about 13% of that cohort are actually been waiting more than a year. So as I said right at the outset, we've done a lot of work to segment this waiting list to really understand complexity, need, and time urgency, really. So we've got about just over 4,000 patients that we've identified that need to be treated in the next few months. This priority 3 cohorts that I talked about. And as I said, that's our focus. So our focus over the first 2 quarters is to treat those patients. Clearly, another significant priority of the system is cancer restoration. So during the first wave, what we saw was a historic high of patients who had been waiting longer than 62 days for their first definitive treatment for cancer. And it reached this peak of just under 800 patients in May, which was really alarming for us, really significant issue that we had to resolve. And we spent a lot of time in the summer months bringing that number down, and we were successful. Actually, we really got it down to where we needed it to be, and we were seeing a month-on-month reduction. But as you can see in this graph, for both Derby as well as Chesterfield, the numbers have started to increase again as we've gone through this second wave. So a bit of good news is that from a March position, we're starting to see the numbers come back down again as we've started to restore more of the cancer pathways. And again, similar to the P2, P3 cohorts, the cancer cohorts are absolute priority. So we need to bring that number down as we go through the spring and summer. So just a couple of last sort of messages, really. So from an elective care perspective, as you can imagine, every piece of capacity that we can create needs to be effectively used and efficiently used. So we're doing a lot of work to make sure that we can just sweat our assets as best as we can, use every single theatre session that we can to its maximum effect. And there are three particular specialties that we're putting particular focus on: orthopedics, ENT, and ophthalmology, because there are big efficiency gains to be made along those three specialties. I mentioned right at the outset that we've got to be maintaining some of the good practice that we put into play during the first 2 waves of COVID. And one of the big game changers really is about how much care we can deliver for patients without them having to come to the hospital, so either over the telephone or through Skype or MS Teams, just a more interactive way of delivering care. So there's some really innovative initiatives that we'll keep continuing to deliver over this period. We actually put quite a lot of good services into play, primarily as COVID responses. So, for example, patients who perhaps were incurring some sort of low-level vision issues, who may have gone to the hospital and seen a physician in the hospital. We actually invested in optometry capacity in primary care, where a lot of those patients could actually access it from an optom. So that's something that we want to maintain as good practice going forwards. And lastly, you may be aware that clearly the NHS requisitioned the use of the private sector hospital sector over the last 12 months. And the independent sector will continue to do that as we go into this new financial year. So really important aspect to our elective care delivery. So using the Nuffield next to Derby, using the Balber up in the north of the county, because as I said, every piece of capacity that we can access, we need to be using. And then finally, one of the big sort of constraints to good elective care performance is access to diagnostics, that right at the front end of that pathway. And a lot of the backlogs that are built up are actually will need to go through a diagnostic pathway to rule in or rule out a particular disease or condition. So over the next 12 months, we'll actually be increasing our community diagnostic provision and putting it into locations that actually means that we can start to turn that pathway around a lot quicker than perhaps we've been doing over the last year or so. And then finally, about primary care. So as Steve was saying earlier, most PCNs are in the business of delivering this ambitious vaccination program, but also since March and coming into this month, PCNs are now turning their attention to delivering business as usual. And there are some key aspects to that, as described in this slide. A real focus on ensuring that adults in particular who with a learning disability can have the health checks that they need. Children's vaccinations, getting that program up and running again. A real focus on ensuring that we can diagnose cancers and invite people back into GP surgeries so we can direct them to the hospital as required. A big focus on the screening programs of all types. The flu vaccination is going to be another aspect of our primary care capability that's going to be tested in the second half of the year. And really importantly, actually, the offering that primary care gave to care homes during waves 1 and 2 is a really good news story that will again be maintained as we restore primary care services. So next steps. So quite a lot of work to do, as you can imagine. we're going to be clearly maintaining progress of our understanding of risk of patients on a waiting list. We're going to be focusing a lot of work on that kind of interface between primary care and the hospitals to ensure that the pathways are as synchronized and flow as efficiently as possible. We've got a lot of work to do to submit our sort of medium-term recovery plans in the next couple of months, which is going to be all encompassing. As you can imagine, I think probably a lot of this presentation has been very much hospital focused, and we're doing a lot of work as well to ensure that there's a sort of synchrony really between primary care restoration, hospital restoration, mental health and community, because it's clearly the interdependencies of all sectors restoring at the same pace that will make the overall system more effective. And then finally, just what does the flu situation look like in the winter? And what does a COVID position look like? So more modelling work that we're doing in that space. So I hope that's been helpful. Hopefully it gives you a bit of a sense of the sort of complexity of the sort of territory that we're currently on in the NHS, and happy to take any questions. Thank you.
Thank you, Craig. Thank you for providing quite a comprehensive overview of what's happening in our hospitals. Well, first of all, can I thank all our colleagues who work in the health sector for working and doing their best under very difficult circumstances and providing care to patients and those people who need a treatment and intervention, medical interventions, as I say, during a very difficult time for everybody around. Secondly, do correct me if I'm wrong. My understanding is that the waiting times and the waiting queues were both lengthening before the onset of coronavirus, and that had been happening over months and years in a steady way anyway. Now, because of coronavirus, obviously those queues and those waiting times have lengthened even further. Now, it doesn't really matter how well you're organized at local level. Without significant additional resources, it will be difficult for us to shift the backlog, which was already accumulating and has now assumed significant proportions in that sense. Do you see, without significant additional resources coming from the central government and some coordination actually happening at that level, that we will actually be in a position to bring the backlog to a reasonable proportion?
Thanks, Councillor. Absolutely, that's the key question, really. So it's probably worth saying you're absolutely right that from a planned elective care perspective, we entered this pandemic with a fundamental mismatch, really, between the demand coming into the system and the capacity that we have to treat. Okay, according to the sort of time limited targets that clearly the NHS has to deliver, quite rightly, and clearly the COVID pandemic has just exacerbated that position. In terms of our recovery, so this is going to be a multi-year recovery. So we haven't landed on kind of where we think we're going to be and how quickly we think we can kind of get this back down, but it's certainly 2 years or more. This isn't something that's going to kind of just be solved overnight. In terms of resource, so through the recent government announcement of extra investment into the NHS, we've got something called an Elective Recovery Fund, which is specific monies targeted for bringing back volumes of elective operating. So that is new money coming into the system. How we deploy that is going to be the key test for us. So whether we've got enough money to kind of do everything we want, well, we'd want more money as the NHS, but actually we've got targeted funding now coming from central government into the CCG's allocations for the system to allocate on this really important priority of restoring elective care. Now, I think one of the big things that we saw through the pandemic was how the need to join services, to join hospital services together, where actually we were seeing capacity as one, as opposed to the capacity of this hospital versus that hospital. So I think what we'll see actually in the medium term is a much more effective use of the capacity that we have. So potentially there might be issues of where we might have to trade choice off. So if a patient perhaps doesn't want to get treated in one particular aspect, but actually can get treatment quicker, then actually we might just want to say, well, that's where you've got to go. So there's a lot of intersections here. You've got the intersection of choice, you've got the intersection of money coming into the system, new money coming into the system to bring about a better recovery for elective care, and you've got this precious capacity resource that we need to be used effectively. So it's just how we join those three aspects up, really. But as I said, you know, we've got sufficient resource to deliver our elective care ambitions for this financial year, and what we'll need next year and the year after clearly is another position. But yeah, it's a tricky one to kind of to answer, because there are so many variables at play.
Okay, thank you. Diane, you've got your hands up.
Yes, please. Evening, Craig.
Hi.
Hi. Just a wander back to 111. As we know, GP services are still overwhelmed. People are still having problems contacting them for, anything really, from a bruised thumb to whatever. Has the uptake of 111 and the walk-in centres, has that gone up?
So that's really interesting, Dan. So there's a couple of things there. So certainly in terms of 111 first, the numbers have been just really, really high. So the number of
passing people onto them. Sorry.
but I mean, so we've put investment into that service and it's being used. The urgent treatment centre. So colleagues will be aware we've got 5 across the entire county. Clearly, one in Derby City. What we haven't seen is the level of recovery of patients going to those centres as we've seen, say, patients going to their local A&E. So a big question for this system is, why is that? And actually, are those services fit for purpose? What do they need to be perhaps repurposed as, so they actually get used more? So there's a lot of this concept of kind of wrapping around more services into those physical locations is something that we're actively looking at. But to answer your question, Dan, clearly 111 is being used. Yeah. UTCs, we've got to use them more. And there's a hell of a lot of work going on in the 2 acutes to sort of say, look, how can you kind of turn these patients around, bounce them back into a more appropriate setting, as opposed to waiting hours in the AD department. So
what I'm finding is, because we have Horizon Healthcare, I'll let that matter drop. But what happens is they're calling me, I can't get through, blah, blah, blah. I'm sending them to 111 to go to get an appointment at the walk-in centre. That's for homeless people. That's for people who don't have GPs. And I think this is what we've got to try and get across to people. If you cannot get an appointment, you cannot get through to your GP, ring the 111. You can go to the walk-in centres. They just don't think they're for people who have a GP. Absolutely. And I think this is what's getting the mix up.
Absolutely. Yeah. No, I think we've got to make this system much more simpler for patients to understand and use clearly. We've done a lot of work to get the messaging right. We can do a lot more in that space. One of the things we're also doing is joining up 111 more proactively with general practice. So sort of, and Steve will know a lot more about this, but kind of creating dedicated capacity within primary care to say, if a patient is entering 111 and actually that patient can be managed effectively in primary care, actually we can plant the patient back into primary care at the most convenient point. So yeah, it's spaghetti junction, all of these different entry points, but we're doing our best really to kind of make it as a simpler flow as possible.
Oh, good. Thank you.
I can't see anybody who has raised their hand to ask a question. If there are no more questions, can I thank Steve and Craig for bringing us up to speed with what's happening in our localities, etc. And with that, after thanking them, can I move on to the next item, which is item 6? And that covers the anticipated impact of COVID on the community. I haven't got a name. Are you, Robin, covering that one?
Yes, that's me.
Oh, is that yours? Okay.
Yes.
What do you then?
You're the lucky one.
I'll just bring up the presentation for you, and hoping that's displaying all right for you. Are you able to see that okay? So there's a number of different aspects within this, as we discussed. Councillor has saying that I'm going to cover. So just to start with, the current situation of COVID in the city, and this is from our latest epidemiological report, which takes the data up to the 10th of April. We will have a refresh report coming out tomorrow evening now on the latest data. But you can see from that really good progress with the numbers of cases. So the latest case number is 57 cases in the week, which is a rate of 22 per 100,000 population. And you can see from the bar chart that we've come right down, and we're actually at levels very similar to September of last year. What I would also say is that although not all of our tests go through to check for the Kent variant, there's around 95% of those that do go through that are the Kent variant. So it's clearly the dominant variant within the city, but also across the country now. There was a specific question, Councillor Hussain, around progress with treatment, and just an understanding that as the pandemic has progressed, the understanding of coronavirus as a condition and the treatment and the correct treatment and the best treatment for that has improved greatly. So just really some headlines around what's happened over that time. So there's been an increased understanding of the process of the disease and the role of inflammation within that, and the really excellent discovery of the benefits of dexamethasone, which is a widely available and cheap drug, which has worked very well in reducing the impact of coronavirus for those people who've been admitted to hospital. And there are other rarer, more expensive drugs that have also served this purpose around reducing inflammation. What's also been identified is the clotting risk, and I know there's been concerns recently around the AstraZeneca vaccine and clotting risk, and you will have heard in some of the explanations around that even if there is a risk between an association between clotting and the AstraZeneca vaccine, there is a much stronger association between COVID infection and clotting, and an understanding that actually people who are admitted to hospital now with coronavirus infection need some prophylaxis to prevent clotting, because they are at such much higher risk of clotting, and the use of heparin injections to prevent that. There's also been some better understanding around how to assist with breathing, including the positioning of patients, so positioning of patients on their front, so it's much easier for them to expand their lungs, and also how non-invasive ventilation can be used. So this can be oxygen, it can be positive airways pressure through wearing a mask with that non-invasive ventilation of oxygen. There's also been increasing evidence around those treatments that haven't been shown to be effective, and that includes antibiotics if there isn't a bacterial infection associated. The use of plasma, there have been a number of trials around antibodies and the use of plasma, which haven't shown any evidence of effectiveness, and also hydroxychloroquine as well, which hasn't shown any evidence of effectiveness. But there's obviously a huge amount of research into this area to look increasingly at any further treatments that may be of effect. So the next question was what might be ahead, what might be coming this year, and Craig has alluded to some of that. So there is a huge amount of uncertainty, and to just run through those issues here that may create that uncertainty over this coming year. So the vaccination and immunity, we are doing brilliantly in Derbyshire with the uptake of the vaccination programme. But we're still not there. We still have significant numbers of the population who aren't fully vaccinated. And we don't have a full understanding as yet how long that immunity is going to last from that vaccination. So there's a lot yet to learn around that. We are undertaking the relaxation of the measures, and we need to see how well the population follow those restrictions and the guidance that's in place. We know that everybody has had a really difficult year and is really keen to move to a situation as being back to normal as much as possible, as soon as possible. But it's really important that we do continue to follow those restrictions in that stepwise manner. And following on from that, there's some uncertainty around the details of step 4 of the roadmap. So currently the plans in June, all we really know around that is a plan to relax the legal measures. But what we don't know is what guidance or other measures may need to be in place at that time. We know that when we relax in June, we won't have a fully vaccinated population. And this does put us in a position of risk, because we are aware that those people who are unvaccinated are probably those who are also mixing the most likely to be out socialising or working out of the home. And so there remains that risk that that unvaccinated population may be a trigger for developing a further wave of coronavirus. We're not sure at the moment of the impact of seasonality, and SAGE have done some modelling to look at when we might expect a further wave of coronavirus. I like to feel quite positive about seasonality. I think if we look back to last summer, we can see that actually there was quite a lot of socialising and quite a lot of activity without any vaccination in the population, and yet the numbers did remain quite low. So I am very hopeful for the summer and the impact that will have, but we're not sure. We can't be certain around the impact of that. We also are not clear what appetite there may be to change the timeline or the measures. So if we get into May or into June and we can see a resurgence of the virus, whether there'll be a political or a societal will to return to any measures, because, as I said, the population are really keen to move on now. And also variants of concern, as mentioned earlier. So the more that the virus circulates within the population, the more that it multiplies, the higher the risk of creation of variants of concern. And the issue as we increase the coverage of vaccination in the population is that creates a pressure on the virus. It's almost like a natural selection of the virus. And so if there's a variant that does develop that is in some way got a reduced impact from the vaccine, then that variant will be given an advantage within spreading within the population. And so there is, again, uncertainty around that. And we've seen the development of variants really in those countries where the virus is spreading really, really vigorously, as we've seen in Brazil and in India. So that remains something that we really need to monitor closely. So what do we anticipate? As mentioned, SAGE have done some modelling, and they are fairly convinced that there will be a third wave. It's described as possibly as large as the first wave that we had at the beginning of last year, particularly if numbers start to increase earlier in the summer when vaccination levels are less complete. But if we manage to follow the measures, if we manage to follow the guidance that's in place and hold back that increase in viral transmission whilst we manage to increase the vaccination of the population, we have a good chance of reducing the size of that wave. But there's a huge amount of uncertainty around that, and it's dependent not only on what we do within Derby, but also what happens across the rest of the country. But we do expect numbers to be low at least until late May. What is predicted is that 60 to 70% of hospital admissions and deaths will be in individuals who have received 2 doses of the vaccine. We must remember that no vaccine is 100% effective. And that's why it's really important to maintain those measures, even in people who have been fully vaccinated. The protection we get from a vaccine comes from the vaccination within ourselves and the production of antibodies within ourselves, but also from a reduction of the prevalence and circulation of the virus within the community. So we may have good protection ourselves, but we're also less likely to meet the virus as we go out and about our daily activities. And we also know that we're much likely to see much greater variation across Derbyshire, but also between counties and regions. We know that inequality is driving the transmission of the virus and also the uptake of vaccine really significantly. So those communities who are more deprived, perhaps who have populations who are out at work more, mixing more, and also potentially with lower uptake of the vaccine, we're much more likely to get outbreaks within those areas. So the impact on the community has been looked at. We don't have data as yet fully for the city itself, but what we do have are the national work that's been done. So Marmot undertook a COVID-19 review, Build Back Fairer, which looked at some of the key impacts. And we know that mortality from COVID has been affected by health conditions, by deprivation and inequality, by living conditions, by occupation and ethnicity. And all of these things have added together to increase vulnerability of individuals, along with those individuals who are male and those who are older. We know that children have suffered really significantly from the impact both of coronavirus within the community, but also from the measures that we've taken in order to reduce the spread. We know that there's an increase in child poverty, and we are really concerned around the impacts on mental health and also the exposures that we don't know for sure, but do believe that have happened to children around potential abuse or witnessing abuse. And also we know that youth unemployment is significantly impacted. When we look at behaviours, containment and isolation have impacted many behaviours, including smoking, alcohol intake. We know that obesity has increased, and we know that mental health has deteriorated, and those at risk of violence and abuse have also increased over this time. But we also have further data that's come from Public Health England, which has looked at survey data. And we can see from that, again, national data, an increase in anxiety, depression and loneliness, and a decrease in life satisfaction. I don't think that's a surprise to any of us that that's happened. An improvement in air quality, as you would anticipate from the reduction in individuals moving around, although there is a great concern as we move through this year that air quality actually may reduce to exactly the position it was before the pandemic. On alcohol, we've seen a decrease in intake in 18 to 34-year-olds and an increase in 35 to 54-year-olds. And that probably relates to the most likely place that individuals drink. So 18 to 34-year-olds probably more likely to be out socialising when they're drinking. 35 to 54-year-olds probably more likely to be at home. And also we've seen an increase in alcohol-specific mortality. So really significant alcohol intake and the significant impacts of that on health. There has interestingly been an increase in those quitting unaided. So without seeking services, without using nicotine replacement. But we're expecting that there's been an increase in the inequality in that quitting of smoking, so that we would expect to see those from more affluent groups quitting more and those from more deprived groups, and certainly the routine and manual groups, quitting less. And we know that there's been an impact on life expectancy just from the increased mortality from coronavirus. So over the coming year, from a public health perspective, we're very much continuing to respond to the pandemic. We're anticipating a further wave and the work that we need to do to reduce that. And as Steve mentioned earlier, a huge amount of work linking in with inequalities and the vaccine uptake. We're also continuing monitoring the accessibility of testing in the city and ensuring that both symptomatic and asymptomatic testing is accessible. And we have taken on over the last couple of months local zero contact tracing, which is immediate contact tracing undertaken by the local area. So cases are passed immediately to us, and we try to contact all of those positive cases, which enables us to have that local discussion and really understanding individuals' challenges if they need support to self-isolate. We're continuing to review the emerging local data to assess what the wider impacts are for the city and to prioritise our response. There is a national dashboard with wider impacts of coronavirus on health. Currently, that data reported is only up to 2019, so we are waiting for an update on that, which we're hoping for soon, so we can really assess the impact for us. And then there's also a national direction for public health programmes and some ring-fence monies that are being transferred to local authorities, specifically around managing obesity and also for alcohol misuse as well. So we're continuing with all of that work whilst also looking to assess exactly the impact on us as a local area from COVID. So if I stop sharing that. I'm very happy to have any questions on that first section.
Thank you, Robin. I've got one or two questions which have come into my mind. First of all, do you have any data on increased poverty as a result of COVID restrictions that were introduced to stop the spread of coronavirus so quickly?
I don't have any actual data at the moment. We can certainly have a look into that. But what we know is, I think we're really concerned around the unknown impact around furlough and what we may see over coming months as the furlough programme comes to an end, and that anticipation of increased job losses through that time. So I think at the moment we don't have firm data, but we are concerned that it may well be increasing over this time.
Okay, and the second question is around the potential third wave. You said it could be triggered as early as end of May.
So the case rates are expected to be low until the end of May, but we know that we've got the relaxation of measures on. If data is looking good, we're relaxing measures on the 17th of May, and it takes about 3 weeks to fully see the impact of that. So we would anticipate any impact of those measures to be coming towards the beginning of June.
So we could begin to see a rise again, potentially, in beginning of June, because the impact of relaxation mid-May will probably begin to come in a little bit then.
I think we're running this sort of tightrope at the minute with the relaxation of the measures and the implementation of vaccination, and there's an interdependence between the two of them. So the faster we progress with vaccination and the more that everybody adheres to the measures and remembers social distancing and hand washing and face covering and all of those measures that they need to keep in place, the better we are with that, then the further we push out that increase in rates and the lower our peak will be. So it's very much a balance between the two and progress with the two.
Thank you. Di, you've got your hand up.
Yes, please. Evening, Robin.
Evening.
I mean, it is going to be a concern at the end of May. What I'd like to ask is oh God, there goes the dog. If we stop laughing, if we start to see a difference in the COVID coming back up again, can we take measures locally, or do we have to wait for the national guidelines to come through, which take at least 2 weeks before they hit us, which gives Derby and Derbyshire, another 2 weeks, and it'll just keep expanding instead of us getting on top of it first?
So I think there's probably a couple of aspects to the answer of that, isn't there? From a legislation perspective, we have limited areas that we could take action on. But what we've been very much focusing on from a city perspective and the environmental health, food and safety team have been absolutely key to this, is the engagement with businesses or venues or areas when we see that there are issues, when we are concerned. They've been building up some excellent relationships and having those early conversations. So even if we don't have the ability to use legislation, we've got those relationships and the discussions and the advice that we can use with individuals. The actual legislation for us locally mainly relates to particular premises or particular events rather than looking at a population-wide impact.
Thank you. Just wanted to get on top of it.
Okay, Eric, yeah.
How is test and trace going on in Derby and Derbyshire?
So we've got really good access to testing in the city now. We've got the 4 symptomatic testing centres which have great availability. They are not used to their maximum capacity at all. So from the perspective of individuals with symptoms, really easy to get a test. We don't have any control locally around how long the results take to come through, but they are much quicker now than they were when there were issues around the autumn. From an asymptomatic testing perspective, there's also the availability for people to have those tests at home now, so everybody can have a home test and be undertaking that testing twice a week if they wish. And we'd particularly promote that to people who are out and about, so people who are potentially at risk due to being out at work or other contacts that they may have. From a contact tracing perspective, we're now undertaking all of that locally. So when the positive result is given, it comes straight through to our team now, which is linked up to Derby Direct, and they're making phone calls, and if they're unable to contact individuals, then the PPOs are going out to do visits as well to follow up on that. The main issues that we have with being unable to contact people is either because they're actually quite unwell, and sometimes actually in hospital, so we're unable to make those contacts. And the other issue is just sometimes the details are incorrect. But they're the main issues that they come across, and the PPOs are actually having really excellent success when we do have difficulties with the door knocking. They're not asking questions on the door, they're just saying, we're trying to get in touch, this number's trying to call you, if you want to give them a ring, or please do answer when they phone you, just to encourage them to engage, and people do. And I think the opportunity of having that really early conversation is really positive, because people are much keener to have that conversation on their first or second day after diagnosis, rather than we were getting difficulties with cases being passed sort of 7-8 days, and time's passed by then and we've missed that opportunity. So now we're getting them straight away. I think that's it's a much better opportunity. As the numbers drop, I think that gives us even better opportunity to really understand and have in-depth conversations about any barriers individuals may have as well, so we can connect them up to see whether they're eligible for any of the grants or other support that's available.
Excellent, thank you very much.
Robin, I think we've got a good opportunity now because numbers are quite low. And as numbers begin to trickle in, I think we've got greater opportunity to suppress it here, because it's easier to trace and track people when numbers are really very small. Once they start spilling into hundreds, then it becomes a bit haphazard, and it's a bit of a hit and miss case. So I think if you've got all the arrangements in place now, we just need to sharpen our act and make sure each case which gets to our notice now is properly traced and tracked, and the follow through is done properly. And I think we've got more than reasonable chance of containing it. But once, as I say, numbers get into hundreds of new cases a week, then obviously it becomes a case of having lots and lots of resources to make sure everybody who may have been in contact with a person who might have been a carrier. It just becomes more difficult to manage the whole operation. And I was just wondering whether, you know, we can do it now, because the numbers, as you say, are pretty low. And if we get onto it, you know, as quickly as possible, and then make sure we made contact with everybody who might have been in contact with the infected person.
It is a really good opportunity. I think the issues that we're still going to come across, though, are some people don't want to come forward for testing. Some people don't want to have a positive diagnosis because of the implications that may have for them. And that is that issue around ensuring people are well aware of what benefits are available. But then we've also got the issue around isolating once people know that they are positive. And I think that phone conversation is an opportunity to check out if there's any barriers and any assistance that may help individuals to isolate. But it is a national issue, they wanting to come forward for testing and feeling able to isolate within many different populations nationally. That seems to be one of the biggest issues.
Okay, I can't see anybody else. I just wanted to ask a question. So
can I just thank Robin and her staff, because my husband had a call out of the blue because he was on the danger list, you know, and he was quite shocked, should I say, to receive this call, and he was very highly praised of it. He thought it was excellent, and if everyone is getting that sort of phone call, then I think it will put a lot of people's minds at rest and help.
Thank you.
So yes, say thank you to your staff for me.
Thank you, that's
excellent.
wonderful. Great news.
okay, did you have a bit more to say? Is there a second part to your presentation, Robin? Or
it's the next section, I believe, around childhood vaccination was the was the next one.
Then, well, we could seamlessly slip into that one.
Seamlessly slip into that one. So if I just pull these slides up again. So just to say, if anyone can remember back in the mists of time, in February last year, we had a meeting in the council house where we went through childhood immunisation, and at that meeting it was suggested that we have a follow-up to check on progress. So this is to look at the progress since that meeting, to just provide some reassurance around childhood immunisation, and also to just highlight some relevant changes to the public health system that you may well have heard some bits about. So looking back at my final slide from the presentation of last year, these were the points that I'd highlighted to you. So that we were planning to continue to seek assurance of children's vaccinations through the Derbyshire Health Protection Board. And the Health Protection Board has met once since that point. We have reduced the frequency of those meetings because what we've done is realigned into the COVID Health Protection Board, but we will be re-establishing those meetings and we'll be able to provide you with a further update following that. The work that we conduct around childhood immunisations is with the Screening and Immunisation team, which is a team from Public Health England who are based within NHS England. They are the commissioners of the childhood immunisation programme, and they, as PHE staff, were reallocated during last year to respond to COVID, and were only put back into their screening and immunisation role towards the autumn of last year. And obviously locally as well, we have been incredibly focused on the COVID response. And just to note that the national public health functions are currently undergoing reorganisation, so discussions around actually the responsibility for screening and immunisation sitting with the local integrated care system rather than sitting outside of that with NHS England. We're not clear yet what's going to happen with those public health teams and where they're going to be sat, but we're keeping close eyes on those developments. And the final one was we were anticipating a national strategy around immunisation to be published in the spring of last year. We're still currently awaiting, and this is probably going to look considerably different to what it would have looked like last year. So just to run through some reassurance, really. So this is national data looking at diphtheria, tetanus, pertussis, polio, Haemophilus and hepatitis vaccination up to 6 months of age. So these are the vaccinations that are delivered to babies at 2, 3 and 4 months. And I think it's just really, really reassuring when we look. The blue line there is the numbers of children being vaccinated in 2019 nationally. And then we can look and see what happened in 2020. And you can see that there was some variability, there were some changes, but actually it was really, really well maintained. And this was down to practices maintaining their focus. And I'm sure parents of those really young children were well engaged with health services and were happy to use those health services as well. So I do think, although there is a small impact there, I think that's really, really positive news. When we look at the MMR between 12 and 18 months of age, so a slightly different age group, perhaps parents not quite so engaged with health services as those parents of the babies. And you can see just around the time of the lockdown, between sort of weeks 11 to 15, you can see that dip in performance in 2020. But for the rest of the year, it's pretty good performance compared to 2019. There isn't really a significant impact. And when we look at what's happened in Derby, so what we've got here is the vaccination coverage data for various different vaccines. So we've got that diphtheria, tetanus one is that first one on the line, pneumococcal is the PCV, and then we've got meningitis and the MMR vaccines. And these are doses at different age periods. But what you can see is in 2019, 2020, generally speaking, performance was around about or slightly below the England average. And when we look at the latest data, which is Q3 for last year, so looking at the autumn period, you can see that it's been relatively well maintained. For some vaccinations, there's been an improvement. For others, there's been a slight dip. But we know when we look at only 1 quarter of data, there's a little bit more variability than that, than we would see over an entire year's worth of data. But it really is, I think, really reassuring compared to what's happened with the population's willingness and desire to access other health services. Actually, the children's vaccination programme has been relatively well preserved over that time. But we do know, and particularly around that second MMR vaccination, there's a lot of work to do. We can see that in 1920, we were at 83.8% of the uptake of that second vaccination by 5 years. And we know, just like COVID, that second vaccination is really, really important to ensure that there's maximum immunity in the population. And you can see that the latest data for Derby, 82.3, there's still considerable work to do, particularly with that vaccination. So I think just to highlight finally, there's some key opportunities for us in the coming year. So the transfer of the Public Health England and NHSE responsibilities for commissioning vaccination programmes, I think this gives us a much more local oversight and much more ability to understand and work with that locally. But we are still waiting for that national strategic direction on this to see exactly what the implications will be. As Steve mentioned earlier, there's been extensive COVID vaccine inequality work, and there's some really good learning that we've got from that we can transfer through into other vaccination and screening programmes as well. And throughout the pandemic, there's been some great work to develop some really strong working relationship with the communities and with the voluntary sector in the city. And it just puts us in a really good position now for going forward and looking at how we can all work together to improve childhood vaccination. So although, just to summarise, the pandemic hasn't had a huge impact on childhood immunisation, but we've still got, particularly around that second MMR dose, we've still got a lot of work to do, but there's some really good opportunities, I think, for the coming year. So if I just stop sharing, very happy to have any questions on that.
Could I kick off then? I've been thinking about this. Before now, I've never picked up on the issue that there appears to be greater hesitancy among some, I think, minority groups when it comes to vaccinating children. Now, obviously, if there was something which was deeply embedded either in culture or religion or whatever tradition, then that would have shown in other vaccination programs as well. I was wondering why that has not happened before, because as far as I know, vaccinating children from a minority background hasn't been much of an issue, or is it something that's been there but we've not uncovered it?
So I think there's different issues relating to different vaccinations and different populations. So, for example, there have been concerns around the nasal flu vaccination for children because of related contents of that vaccine, and there has been a lot of conversations and discussions around that. But what is often the case is that there's many factors involved in reduced uptake of vaccinations, and sometimes it's not necessarily about a reluctance to have the vaccine. Sometimes it's about the accessibility of services or everything else that's happening in life. And I think this is part of why we see the vaccination uptake in that 2, 3 and 4 month old is often the best performance, and is a time when parents are really well engaged with their health services and aware of the appointments that they need to go to and have good close relationships with health visitors and others working with them. As the children get older and those relationships get less intense as they are within the first months of life, we see that vaccination levels tend to dip, and we can see that over these vaccines as well. So once you get to that year vaccination, actually for most families, there's not a huge amount of contact with health services unless there's illness at that point. So sometimes this is about what else is also happening in the family. So once you get into 1, 2, 3-year-olds, perhaps you have other children, perhaps you've got children at school, perhaps you're no longer on maternity leave. There's all of those other wider aspects in accessing vaccination that it's complicated. I think it's often multifaceted as to why there's issues, and I think that's part of that importance of working with the local community and really getting underneath, because there's probably different groups there with very different issues that we can support.
Okay, Diane?
Yeah, hi Robin again. I know it's a long time since I was at school and having immunisations, but do they still do the rubella for the girls? Or is it 10 and 15? Do they still do that?
No, so rubella's within the MMR now. So
right,
it's universal,
they don't
all
have
children.
The ones at the teenage level now.
No.
Right, I just wondered why there was no teenagers in all the graphs. I'm thinking, I'm sure I had some. I'm old.
So certainly when I was at school, there was a rubella for girls and a TB vaccination as well. And the TB vaccination changed to being babies at risk, so either living in a high risk area or being from a family who has extended family from a high risk country. So it's a targeted vaccination program now. What we do have is HPV vaccination, which was originally brought in for girls and is now boys and girls, and that's the cervical cancer prevention vaccination. So that's the one that's delivered in year 8, 9, and this past year has been the first year of boys receiving that as well.
And has that been continuing because they've not been at school, have they? I mean, do they go to the GP or do they have it at school like we used to?
Yeah, so they have it at school, and I am waiting to see what happened. But last year they deliver it, the school nursing or the school immunisation team deliver it usually in the summer term. And last year, Derbyshire Community Health Services were delivering that, and they delivered a fantastic mobile vaccination programme. So using drive-through vaccinations, which received quite a lot of national coverage as well, actually, for their innovation.
Must have missed that bit.
But what we're still waiting to look at is what the impact. Obviously, it's really good uptake for people who've got cars and for whom that's accessible, and they did look to delivering it in different ways in different communities for people who might not have cars, but we're still waiting to see actually what the full impact of that was and whether there's any inequality aspects that we need to be picking up. But that's the school age vaccination, along with boosters now that come, a sort of pre-university booster that comes as well.
Thank you.
If there are no more questions to Robin, then can we move swiftly to item 8, because I need Robin's help with that item as well. It's our work program, and the work program, we decided to look into issues arising from spread of coronavirus at the time and the impact it was having on our older residents, and particularly residents who were being cared for in nursing and residential cares. The idea then was for us to, this is before it really caught fire and it spread like wildfire. We thought we might be able to talk to some residents and their carers and get their perspective on the whole issue. As things turned out, because the spread was so quickly and the precautionary measures that were taken, it made that aspect very difficult, almost impossible. And I think we've got to a stage now where perhaps there is little point us kind of going over that issue now, but somehow we still need to conclude the topic review. And I think the easiest way perhaps to do that is if Robin and Kirsty could get together and put a kind of report together which covers the initial period when we identified our initial cases, and perhaps comment on the arrangements, well, not arrangement, but comment on our readiness, if you like. Because obviously by the time we got our first case, we knew it was heading our way, because the first case was identified in China in mid-December. And I think our first case happened to come to the fore probably end of February, was it? Beginning of March?
In the city, like it was the beginning of March, yes.
Yeah, that's right. So we had roughly about 8 weeks. If we had acted very promptly, immediately, we had 8-week preparation period. But my guess is this country wasn't alone, or Derby wasn't alone in this. I think we were quite slow to react and begin to put some preparation in place. But you probably got the ringside seat, Robin, on what was happening. Now, if Kirsty and yourself could give us a bit of a story around that, and then ultimately the focus is going to be, could we have done better, and perhaps make some recommendations where we could have done better to make things easier for everybody around. That's my suggestion. Di, do you have any comments in terms of how we proceed? Because we've still got to go ahead and, ideally speaking, the topic review should have been concluded in this meeting, and the report should have gone to the cabinet perhaps early next year. Yeah. But because of the circumstances and understandable reason, all the focus was on containing COVID virus. and this took a backseat because I think in overall terms of priorities, that was the right thing to do.
Yeah.
But we still need to perhaps do something about it early next year to get it out of the way and then pick another topic for next year.
Yeah, I think we need to know the timescales, because a lot of it, I mean, although we're saying Derby didn't really have a case till March, we all know that this was here way before March. You know what I mean? So until we got the national guidelines, we couldn't really act anyway on some of the things. So I think, yeah, in hindsight, let's have a review, see what the timescales were coming in from national. Could we have done anything before the national guidelines come in? You know what I mean? And see if we could have preempted it anyway.
It's just to get a picture, a holistic picture in a sense, but you're quite right. I think we were relying on government to produce some guidelines, and the government was relatively slow, so therefore that then percolated. You know, the effect was, ripple effect was.
Yeah, I don't think we had.
It's not point fingers, but if we are able to tell a story in terms of how the whole thing unfolded.
Yeah, I think what it is.
Where the government could have acted quickly, where local authority could, it's just
we don't have enough legislation in to act on something like this. I mean, nobody knew a pandemic was coming. Nobody knew how hard it was going to hit. So I think really we should find out what actually did happen, how it happened, and could we probably get some sort of legislation put in within the city, you know, the city boundaries in Derbyshire and what have you, and see if anything else like this ever happens. Like we said, if there's third wave coming, can we act before the national guidelines come in? Can we preempt national guidelines with some legislation of some kind?
Yeah. Because at the end of the day, we've got to pull it together and put forward some recommendations. Yes, Eric.
Just briefly, we have to beware when we're doing this analysis to avoid hindsight. It's. I mean, I've looked back at what I've done and failed to do. You think, well, I didn't know at the time that I should have been doing X. So just beware.
Sure.
Okay, thank you.
Okay. Lindsay, you're going to have to coordinate this somehow. I don't know how. Have you got any comments?
Has she gone home?
Lindsay, are you still there?
Can you hear me now?
Yeah!
Oh, so sorry. I was trying to unmute myself and it just didn't work. Yeah, no, you've
watching football.
No, I was here. I've been here and I've been listening to you all. That's been very interesting. Yes. No, you've outlined what you want, and I don't know whether is it possible to pull together something briefly, Robin? Do you think, given your workload?
I think there's certainly it's how we do it, isn't it? But there's certainly some points we can bring together there, and there's Councillor Ashburn points out that the benefit of hindsight. Actually, in March last year, we had no information about the cases in the city, and I think that's a really important aspect to it around where we were and how far we've come, and the detail that we now know that we just didn't know at that point. And certainly with Kirsty, I can have a conversation, but I think we can certainly look at some sort of summary or briefing around that. When would that be needed for?
our next meeting is going to be, is it in June, Lindsay?
Yes, it is in June. I think it's towards the end of June, but I'd need to
Towards the end of
confirm that.
But don't forget,
Yeah.
half of us probably won't even be on this committee.
We don't know.
This is the problem.
But you could come to the meeting.
Yes.
You could come to the meeting, yes. If we could actually aim for concluding it by, and you know, that meeting in June, and that will then allow us to pick another topic in the following meeting, which will probably be in September. That will give us 6 months to explore something else then. Because if this spills into September, then that won't give us enough time to. And I think the expectation is that each scrutiny overview and scrutiny board completes at least one topic review a year. That's the expectation. Is that okay?
Yep.
Eric, is this your last official council meeting today?
I think he's left.
Oh,
He left, put a message in the. Yeah, it will be his last one though.
All right. Well, we all wish him well with his retirement plans and whatever else he's got in his mind when he's got more time on his hands. And thank you very much. And that brings this meeting to an